The chemotherapy, how it works. The ultimate target of the chemotherapy, as you see, those are several. This is antibiotic, and an antibiotic, this is alkaloid-like. The main target is the DNA. Either will cause damage to an already established DNA, or making a cross-link linkage which prevent DNA strands to separate, to multiply. But the major problem, the major effect of chemotherapy is on DNA. Some of these cells, some of these chemotherapeutic agents may occur in the cell membrane. For example, the cyclophosphamide. They may work on organelles inside the cells, but the main target is the chemotherapy. Some of the cells are working on the spindle rays, okay, like the vinca alkaloids and the taxanes. And some of them they work by inhibiting certain enzymes, like the methotrexate, which inhibit the dihydrate folate reductase enzyme, and the 5-FU, which work against thymidine synthetase enzyme. Now, the chemotherapeutic agents are divided according to their work in the cell cycle. They are having two major groups: non-phase dependent drugs, so that they don't depend on the phase. They work on different phases while the cells are in the cycle, and those usually are killing the tumor cells exponentially with increasing dose, so that when we increase the dose, there is the increase in the number of cells killed. But usually this will be associated with toxicity. Equally toxic, those who are not phase dependent, they are working on cells while they are growing in the cycle, or in resting phase, or in resting cells in G0. Example of these cells, chemotherapeutic agents, the alkylating agents, the cyclophosphamide, this is platinum, 5-fluorouracil, anthracyclines, mainly the adriamycin or doxorubicin. And we have what's called phase dependent, so that those are targeting certain phases in the cycle. And those usually kill cells at a lower dose, okay? And they act within the specific phase in the cycle, either in S phase or G1 or G2, or a mitotic phase. Example of this is the vinca alkaloids and the methotrexate. Now, why we try to know whether they are phase specific, non-phase specific or phase specific? Because when we use chemotherapy, we try to use a drug which works in any situation in the breast, in the cell. It means that either in G0 or in any phase, and we try to use another drug which is a phase specific. So that is the secret of combination. The drugs, we probably use a full dose of each drug if there is no effect from giving both drugs together. If each one having a separate mechanism and a separate toxicity, probably we can use full drug, a full dose of drug from one of these phase non-specific and phase specific, so that we will gain therapeutic advantage. We will not increase the toxicity, and probably it will make the response and the control of cells much better. We will not go to have fine details about each of the chemotherapeutic agents, and you know that one of the main problems and the bad reputation of the cancer chemotherapy is its side effect, and its side effect is quite terrible. However, there are a lot of development in the last 15 or 20 years in order to protect against the side effects of these chemotherapeutic agents. One of the major side effects is the nausea and the vomiting of those patients, and usually there's now an effective anti-emetic, but before the era of aldosterone, usually the patients have a terrible situation regarding the nausea and vomiting, and usually the bone marrow toxicity, and now we have some drugs used to prevent this toxicity, and probably timing of the chemotherapy, which allow time for the bone marrow to heal. And we have the gastrointestinal toxicity, the problem occurring in growing cells from the mouth along the GI tract, which is associated with nausea, vomiting, abdominal pain, diarrhea, and so on. And one of the serious problems for the patient from social point of view is the loss of hair. Okay? And another problem is the knocking of the ovaries in the ladies and the testes in the males, and this will make the patient sterile. It may induce menopause, okay, on those people, and probably the patient should be warned about this, especially if she is not married or she is planning to get children. And one of the problems also the hyperuricemia due to the liberation of uric acid, the end product of protein metabolism, when we have a bulky tumor, so that the uric acid is very high, so that it will give a gout-like problem and kidney stones. Some of these side effects are peculiar. What we said, those are general side effects of chemotherapy, but we have some peculiar for each drug having its own complication. For example, bleomycin, which is antibiotic, it induces pulmonary fibrosis. And the cyclophosphamide, it is famous to do what is called hemorrhagic cystitis. The patient will present with hematuria. Okay. And this comes through the end product of cyclophosphamide, which is called acrolein. And this acrolein, which is, it is the one which causes, it is an end product of cyclophosphamide, which causes hemorrhagic cystitis. And in order to avoid this, probably we can use chelating agents. What is its name? Mesna, methyl ethyl sulfonate. And we have one of the problems, this adriamycin or doxorubicin, it is one of the best drugs used to treat solid tumor. And usually there is a very good response in the majority of solid tumors. But unfortunately, this will cause cardiac problems in the form of cardiomyopathy. Many people, they have weak heart after having a significant dose of adriamycin. And the adriamycin dose is cumulative, okay? So that we cannot give the patient more than 450 or 500 per meter square as a total dose of adriamycin. Otherwise, we will face this problem. And usually there are certain drugs, but they are not commonly used in order to protect against cardiomyopathy, but it seems that this drug, they are not very effective in preventing this complication. Methotrexate also causes hepatic damage. And usually the patients get dark when we use 5-fluorouracil as treatment for breast or colon cancer. Now the response of the different types of the tumors is different. We have successful story in some tumors, and we have bad experience with the others. And we have more or less a response, but it is not up to what we think or what we need. For example, those are the tumors which are probably curable by using chemotherapy, like lymphoblastic leukemia, because you know that lymphoblastic is not a solid tumor. Most of the cells are proliferating, okay, so that will be targeted by chemotherapy. The germ cell tumors, testicular tumors, okay, those are very, very responsive to the chemotherapy, and you can claim cure from using chemotherapy in those people. Also the choriocarcinoma, and the Hodgkin disease, and Wilms tumor. And those are very responsive to the chemotherapy with a cure possibility. Other tumors, they have significant response, but the chemotherapy is not curable for them. But the use of chemotherapy is the cornerstone in the management of those tumors, in addition to the other local modalities like the chemotherapy and like radiotherapy and surgery. One of the tumors which are responding well to the chemotherapy is the breast cancer. but it will be as part of multi-modality treatment. And usually the ovarian cancer. Ovarian cancer are responsive and which help the patient to survive longer. And colorectal cancer, in the past, before 20 or 30 years, the chemotherapy to the colon cancer is not effective. Usually the people used 5-fluorouracil. But nowadays there are new drugs like oxaliplatin and topoisomerase inhibitors, irinotecan or topotecan. They are very useful in the management of colorectal cancer with a significant response. And osteosarcoma and Wilms tumor are responding to the chemotherapy. There are tumors which are resistant to chemotherapy. The chemotherapy almost useless in them. Probably they may respond, but we need large doses. And this large doses in a patient having pancreatic cancer, probably he is going to die before achieving any survival advantage. As we said that melanoma is resistant to the chemo and radiotherapy, some of the soft tissue sarcomas are responding to the chemotherapy, but the majority they are not responding to the chemotherapy, and the use of adjuvant chemotherapy or treatment of soft tissue sarcoma by chemotherapy is questionable. And you know that gastric cancer, also one of the bad diseases which is not responding to the chemotherapy. And you know that the hepatobiliary system, carcinoma in the hepatobiliary system, like gallbladder carcinoma, also they are not responding to the chemotherapy. You know that when we use chemotherapy, the port of entry of these drugs to the body mainly through a venous system, okay? So that we put a venous line or temporarily a catheter, and the drug will be poured into the venous system, reaching different parts of the body. However, the chemotherapy can be given intra-arterial, as I said yesterday, in isolated limb perfusion or organ perfusion, can be given intra-arterial. Drugs can be given intra-arterial. Drugs can be given intracavitary for patients having, for example, malignant ascites with multiple nodules in the peritoneal cavity. We can apply chemotherapy in the peritoneal cavity, and the major one used is the cisplatin, so that this will have a direct local effect in case of ovarian carcinoma, sometimes in mesothelioma, and sometimes tumors from the GI tract. It can be given topically, the chemotherapeutic agents, using cream-like. And this is an example when we have a patient having, for example, skin tumors like basal cell carcinoma, but it is not very effective.